Good morning and good afternoon, everyone. Thank you for joining us today for another in the series of webinars about high-impact practices in family planning, or HIPS. Today's topic is immediate postpartum family planning. My name is Laura Rainey, and I'll be your moderator today. You can see a little bit more about me. I work at Family Planning 2020, where I'm the high-impact practices advisor, working to help countries integrate HIPS into their programs. I was one of the co-authors of this HIP brief. Next. So here's today's agenda. I'm giving the welcome and introduction now, which will be followed by presentations from our 4 panelists with questions at the end of the presentations. I'd like to thank IBP and FP 2020 for co-sponsoring this webinar series. And I'd especially like to thank Ados May, who does such a fantastic job of curating these webinars. I'd like to acknowledge HIP's co-sponsors, USAID, UNFPA, WHO, IPPF, and FP 2020. Next. Here are a few things before we begin. You can submit your questions at any time using the GoToWebinar link, and you can also access the HIP brief on the link. Next. So the high impact practices are a set of evidence-based practices vetted by experts against specific criteria and documented in an easy-to-use format. HIPS help programs focus resources for greatest impact. HIPS can be used for advocacy, to inform policies and guidelines, and to support implementation. Next. HIPS are grouped into 3 categories: enabling environment, systems or structural interventions, which affect factors indirect to contraceptive use. Briefs here include policy and supply chain management. Service delivery, which is changes in the organization of services which directly affect access, availability, and quality of family planning services. You can see this is circled. This is where immediate postpartum family planning falls. Social and behavior change is the 3rd category, which is interventions directly affecting knowledge, attitudes, behavior, and social norms that influence contraceptive use. This category includes mass media and community group education. Next. Today's webinar will focus on immediate postpartum family planning, where the high impact practice is offer contraceptive counseling and services as part of facility-based child care prior to discharge from the health facility. Immediate postpartum family planning is one of several proven HIPS identified by a technical advisory group of international experts. A proven practice has sufficient evidence to recommend widespread implementation as part of a comprehensive family planning strategy, provided there is careful monitoring of coverage, quality, and cost. Next. For some background, offering modern contraceptive services as part of child care provided during childbirth increases postpartum contraceptive use and is likely to reduce both unintended pregnancies and pregnancies that are too closely spaced, both of which are associated with increased maternal, newborn, and child morbidity. After a live birth, the recommended interval before attempting the next pregnancy is at least 24 months based on a consultation convened by WHO in order to reduce the risk of adverse maternal, perinatal, and infant outcomes. Despite this evidence, over 60% of women are not using effective contraceptive within 24 months postpartum to avoid an unintended pregnancy. Next. Immediate postpartum family planning is important because women and their partners often have limited understanding about contraceptive options, return to fertility, and risk of a closely spaced or unintended pregnancy soon after childbirth. Globally, 4 out of 5 births take place with the assistance of a skilled birth attendant, and increasingly these births are taking place in health facilities. Based on a consultation convened by WHO, women can safely use contraceptive implants during the immediate postpartum period, in addition to many other types of contraceptives. There is a need for providers to be competently trained and use up-to-date job aids to offer safe and effective high-quality services. Next, what's the impact of immediate postpartum family planning? Offering family planning counseling and services at the same time and location as facility-based childcare increases postpartum contraceptive use. The assumption is that there are high levels of facility births among the target population. Next, this table presents the evidence, and it summarizes the evidence from 5 country programs. So as you can see, it's the percentage of women giving birth, leaving the facility with a modern contraceptive method before and after the introduction of contraceptive counseling and services during childbirth care. If you look at the first row for Afghanistan, in the middle column, prior to the introduction of contraceptive counseling and services, the percentage of women leaving the facility with a modern method was 4%. But it increased dramatically to 51% after the introduction of the immediate postpartum family planning program, which included private spaces for postpartum family planning, counseling, and involving husbands and mothers-in-law in counseling. Other immediate postpartum family planning programs and facilities in Honduras, Indonesia, and Niger had equally impressive results when women were offered family planning counseling and services at the same time and location as facility-based childcare. Next, these are the indicators that are recommended for programs implementing immediate postpartum family planning, which include the number and percent of women who delivered in a facility and received counseling on family planning prior to discharge, and the number and percent of women who deliver in a facility and initiate or leave with a modern contraceptive method prior to discharge. These are the numerator and the denominator of the impacts that I showed you earlier. So other information that you can find in this HIP brief includes implementation tips for how to introduce immediate postpartum family planning and programs and projects, which you'll hear about from our next speakers, as well as tools and resources. Next. Now I'd like to introduce today's panelists, Dr. Mario Festin of WHO, Dr. Saswati Das of Jaipago, India, Mr. Michael Muti of Jaipago, Kenya, and Dr. Riaz Mobarakali from Pathfinder International, Mozambique. Next. Our next speaker is Dr. Mario Festin of WHO. I'll let you take it from here, Mario.
Thank you, Laura, and good morning, good afternoon, and good evening to everybody. I'm here to talk about the global guidelines and guidance on immediate postpartum family planning, some of which are from WHO. Next, please. As there's some key facts about family planning and contraception, this comes from the Guttmacher Institute documents. As of 2017, 1.6 billion women of reproductive age group live in developing regions, and about 3/4 of these are already using modern contraceptives. Next. But, next please. But 214 women of reproductive age groups want to avoid pregnancy but are not using a modern contraceptive method. 155 million use no method, and 59 million rely on traditional methods. So this is the breakdown of that 214 million. This has already reduced from the previous 225 from earlier years. Next, please. So this now is part of the key strategy that the WHO and other UN agencies are now using in order to provide universal health coverage. And this is to allow all people and communities to receive quality services that they need and are protected from health threats without suffering financial hardships. So this is the strategy that everybody is now working on, and promoting family planning, including the postpartum period, is one of these implementing strategies. Next, please. As Laura said, immediate PPFP has many important factors. And we mentioned that offering modern contraception as part of childbirth increases contraceptive use and reduces unintended pregnancies and too closely spaced pregnancies. And these actually are associated with increased maternal, newborn, and child morbidity and mortality if not allowed to be prevented. The recommended interval is still at 24 months between from the next pregnancy for the next pregnancy. And as mentioned, 61% of women are not using effective contraception in this 24 months. Next, please. So why do women do not use postpartum contraception? There are sociocultural and gender norms that guide postnatal services, and there and there is the timing of the return to sexual activity. Some engage in sex immediately after or wait for a few more months. Then there are also breastfeeding practices and misconceptions about conditions for lactational amenorrhea, that if you are breastfeeding, you are probably at risk, and it all depends on the level of breastfeeding that you are doing. But a major factor is also the lack of access to contraception. Now, WHO recommends that women receive information on family planning and the benefits of birth spacing at many possible opportunities, including antenatal care as soon as the woman delivers, and during the postpartum and well baby care, including immunization services. Now, actually, each visit to a health provider is a unique opportunity to provide all these services. But there are barriers. The health staff may have biases and lack of knowledge, skills, and support. There might not be supplies and methods available. There might be some misconceptions by the clients about methods. Now, some of the data may not be available or are not gathered at all at some settings. And of course, what was mentioned about sociocultural and gender norms and attitudes. Next, please. So the woman who has just given birth is at risk for an unplanned pregnancy. But contraception is available and can be done depending on her health status and if she opts to breastfeed her child. And as mentioned, the period that she is in the hospital or the facility before goes home is an opportunity to provide family planning. This is the immediate period, or if it's not at that time, it could be when she follows up for her consultation or her newborn. And that would be a delayed or later postpartum family planning. Next, please. WHO has two main guidelines on family planning: the medical eligibility criteria for contraceptive use, which tells us which contraceptive methods can be used given a certain health condition, and the selected practices recommendation for contraceptive use, the SPR, tells us what to do in case there are some problems or conditions which need some interventions for contraceptive use. So the MEC and the SPR are available and have been used and can be accessed through the website's links that are provided there in the slide. Next. We have also developed an implementation guide for the MEC and the SPR. This is to help countries and programs on how to use, adapt, and adopt the MEC and the SPR for their own settings. There might not be all methods available. What can be done in case some providers are not trained? So the implementation guide helps us implement the rollout of the MEC and the SPR, and this is one of the many tools that help in implementation. Next, please. a very popular tool is the MEC wheel. Now, this has now evolved into an from the original printed MEC wheel to an electronic computer-based uh, version to a mobile phone app. And basically, it gives key information from the MEC for starting or continuing use of contraceptive methods. What is interesting and more, I would probably recommend, is that the app, the phone app, the mobile phone app actually allows us to give inputs to more than one health condition, and it kind of helps you choose which methods can be given if multiple health conditions are present in a woman. So the app is very, very practical and useful in the service provision setting. Next, please. Now, for the postpartum period, WHO has also developed this compendium. It is available on this website, srhr.org, and it tells us, it's an interactive website which gives us information on what method to use given the needs and the conditions of the woman. Is she breastfeeding? How many days after delivery is she? And what are her various health conditions? Next, please. So this is the screenshot of the summary of all the methods. The arrow points to the first 48 hours, and it gives us what are the methods that could be provided to the woman in general. And the table and the box on the right tells us what are the contraceptive options, what are available in the immediate postpartum period. It is not only the IUD, it's not only the implants, but we also have sterilization for those who want to limit their number of children. We also have the pills. We also have lactational amenorrhea and, of course, the condoms. And these are all based on the MEC. So this table is very important and can be accessed through the website mentioned. But it also will give us some more information depending on the health condition of the woman. Next, please. So why is this practice important? Providing family planning raises the awareness of birth spacing and the contraceptive option. Now, our goal is to reach the more women and their partners, especially during the facility-based childbirth services, because they are there and they would need the counseling and the services if they opt to have them. And as mentioned, there are, based on the recent evidence in the MEC and the SPR, women now have more contraceptive options in the immediate postpartum period. And the benefits would be improved understanding of fertility and better planning of their of their reproductive careers, and having all of these services available shows increased social support for postpartum family planning use. So there would be increased use of family planning, there would be a reduction of closely spaced pregnancies, and a reduction in unintended pregnancies. Next, please. Now, in order to support this, we have the WHO building blocks in the health system. And this involved looking into the service delivery aspect, the health workforce, health information systems, access to essential medicines, financing, and of course, leadership and governance, which are actually related to putting into place policies to have this institutionalized in countries. So in terms of changes in the health systems, there should be guidelines which can be updated and distributed. The staff would have to be trained and supported and would be able to support counseling and provision of methods. The supplies and the instruments are available. right there in the maternity ward so they could be provided as needed. And of course, we have to we have to respect privacy and have continuity of care and having a good client flow in place. And follow up with community programs should be strengthened as well. Next, please. These are some of the implementation tips. So we need to invest in good documentation and monitoring and to look at the needs of our clients and the community and the families so that there will be voluntarism and informed choice. The national service delivery guidelines should be updated, and also the role of service providers. If there should be a policy related to task sharing that has to be reviewed, we can do that. We also need to conduct formative assessment so that we can guide social and behavioral change strategies so that we don't only provide the services but also the support systems in order to ensure that the women will continue using the method. Now, considering that some of the women would need to stay in the home, they would need to have some home visits as well. So we can also look at leveraging antenatal care visits to educate clients. We should not forget the partners and plan for contraceptive care later, uptake later, if they did not choose to have it in the immediate period. And we have to ensure that staff, equipment, and supplies are available and accessible. But of course, the facility leadership and management practices should be enforced so that there will be quality of care and clients would be satisfied. Next, please. So this is the high impact practice document on immediate postpartum family planning, and the website is shown up there. And this would be very important for us to use as guidance for implementing immediate postpartum family planning. Thank you.
Thank you very much, Mario. Our next speaker is Dr. Saswati Das of Jopaigo, India. She recorded her presentation earlier because she wasn't able to be with us today. So if you can bear with us just a moment while we get her presentation up and running. Thank you very much. Dr. Das is a medical doctor currently serving as the Director, Programs and Clinical Services at Jopaigo.
So my presentation is sharing India's experience on scaling up of postpartum IUCD services. Next slide. So postpartum family planning and it was important in India because 2009 survey found that 65% of women who were within first year after delivery had unmet need, and 26% of postpartum women within 1 year use any contraceptive, and 58.8% of births happen within 36 months of birth interval, and recommended minimum birth interval is 36 months. At the same time, in India, there is a tremendous increase in institutional deliveries. So this provides an opportune time for offering postpartum family planning services. There is an increased resurgence in interest in IUCD, and PPIUCD insertion, postpartum IUCD insertion is convenient. Next. So this is the update from 2010 to 2018. Jopaigo provided technical assistance to establish postpartum IUCD services, rather postpartum family planning and postpartum IUCD services in 19 states, providing technical assistance for different periods of time. And in these states and facilities where Jopaigo provided technical assistance, the number of insertions are 2,075,358. So this is the number in Jopaigo from Jopaigo assisted facilities. Because if we look at the government number, it is PPIUCD insertions during this period, because after introduction of postpartum family planning and postpartum IUCD services, in many states, government scaled it up on its own. Next. So this part of the graph is just to show the pace of scaling up. In 2010, with Japago's technical assistance, postpartum IUCD services were established in 35 facilities, and by the end of 2018, it was in more than 1,600 facilities. This is just to show the pace of scaling up. Next slide. So in these facilities, total insertions were more than 2 million, and these were out of those deliveries which happened at these facilities. So that means 13% of women who delivered at the facilities, they accepted postpartum IUCD. And out of all these postpartum IUCD insertions, 63% were post-placental, that is within 10 minutes of delivery of placenta, 28% within 48 hours, and 9% intracesarean. Next slide. So what happened to those women who accepted postpartum IUCD? They were followed up after 6 weeks of their insertions. So out of 2 million plus insertions, 1 million plus women were followed up, and that makes the follow-up rate 57%. And these follow-up were telephonic follow-up as well as clinical follow-up. And so what are the findings of follow-up? Expulsion and infection, which depend on providers' competencies and following aseptic measures during insertions, were 3.2% and 1.4% respectively. That means more than 95% of PPIUCD acceptors didn't have expulsion and infection. Removal was 6.7%. That means almost 89% women didn't have any complaint. And expulsion, which is the main concern with postpartum IUCD, it has been found that throughout these years, it remained at an acceptable low level, even after withdrawal of Japago's technical assistance from many states of India. And this is a separate study in which found the continuation rate at 1 year after insertion, and this is 62.8%. Next slide. So the postpartum family planning and postpartum IUCD services were scaled up in India using system-based approach, meaning no separate system has been created in the government health service system to introduce or scale up these services. It is by strengthening the existing government health system, and except the technical assistance part, all the implementation cost came from government using NHM funds, and there were some policy shifts also which supported the rapid scale up. Now I'll talk about the 4 focused interventional strategies which helped in ensuring quality during this rapid scale up. Competency building of providers. So 83 centralized training sites have been established in the country, and one doctor, one nurse from each new facility. They were trained at the centralized training site, and within 3 weeks of centralized training, supportive supervision visits were conducted by program staff at their work sites to help them to initiate services at their facilities. And once the services are initiated at their facilities, on-site training were conducted, and within 3 weeks of on-site training, supportive supervision visits were made at the facilities to help the providers to provide services and implement standards. This on-site training was conducted to saturate the facility with all providers, trained providers, so that 24 into 7 services can be provided. Next slide. Second is use of performance standards. The minimum performance standards were finalized by key representatives from each state in a joint platform at the national level, and there are 15 standards for service delivery and additional 13 standards for training sites. And during supportive supervision visits, the program staff helped providers of the facilities to implement these standards and assess the quality of the services periodically. And you can see in the spider cobweb, this is an example of Chhattisgarh and Odisha, where with time the scores on achieving performance standards increased. In 2015, the overall score was 40%, and by 2017, it increased up to 69%. Next slide. So, realizing the importance of counseling to increase uptake of postpartum family planning and postpartum IUCD services, with advocacy, government recruited dedicated counselors for high delivery load facilities. So, these counselors and nursing staffs were separately trained for postpartum family planning counseling, for offering informed choice. They were trained, they were given job aids. Another thing which was done is that counseling corners were established in each facility by carving out some space within the facility to maintain privacy and confidentiality during counseling. And all antenatal clients were routed through these counseling corners. Next. So system was established for following up the PPIUCD acceptors, and their findings were very important. The follow-up findings provided constructive feedback for quality of services for each facility, for each state, and for the national level also. And provider-wise tracking also helped in identifying gaps for each provider. Suppose a provider is seen that there is no insertion by that provider. So immediately it was explored that whether she lacks confidence or what is the problem, or if some infections or expulsions are happening more with cases where particular providers have inserted. So immediately in supportive supervision visits, their skills of insertion, their insertion skills were assessed, and needed hand-holding support was provided by program staff. Next. So, however successful a program is, it faces many challenges, and that has happened with India's postpartum IUCD program also. So it has addressed many challenges, but still some challenges remain to be addressed. And the key challenges which remain to be addressed are that further strengthening of counseling is required, because there are many unnecessary removals due to side effects. Second is post insertion client follow up is important, but sustaining this follow up system after withdrawal of technical assistance is a challenge. Third is establishing an effective system of supportive supervision within government health system. So these are the challenges which remain to be addressed. So the key messages and lessons from India's experiences are that system-based approach with focused interventions helped in rapid scale up and produced positive outcomes. The second is follow-up of clients is very important, which provide constructive feedback on quality of PPIUCD services. And data analysis is important to derive programmatic inputs. That's all. Thank you.
Thank you. Next, we have Michael Muti from Japaigo, Kenya, who will talk about implementation experience in Kenya.
Thank you very much. Good morning and good afternoon. I'll be talking about the lessons learned from the implementation of the post-pregnancy family planning project here in Kenya. Next. As indicated by our previous presenters, the unmet need for family planning within the immediate postpartum period is 63% in Kenya. And we are seeing that despite the WHO recommendation that clients wait for at least 24 months, 23% of deliveries in Kenya occur in less than 24 months. There's also a common assumption that clients will always come at 6 weeks and take up family planning, but unfortunately, only 19% of our clients start using family planning within 6 months. So this project came to address the element of post-pregnancy family planning, which has two components. That is use of family planning after delivery and after loss of pregnancy. Next. As a background, the project is a 3-year study that is being implemented in Kenya and Indonesia, a quasi-experimental design with an intervention and a control county. The intervention county in Kenya is Meru and a control county of Kilifi. Each arm has 23 facilities with 16 public facilities and 7 private facilities. We're not able to share the data that we are collecting from this data as yet because the study is still underway, and we'll be using service delivery statistics to be able to share our experiences. The question we're trying to answer is what are the determinants at service delivery level, at the provider level, and at the client level that really determine use of family planning immediately after delivery and after loss of pregnancy. And we believe the information we get out of this study will be very key in generating actionable evidence that can be used globally to scale up immediate post-pregnancy family planning. Next. So the question is it feasible to provide immediate PPFP in the context of a broader method mix? We tested a few interventions to be able to see whether they are effective in making sure that clients take up immediate PPFP. So next slide, please. The interventions are, as you can see, the first is building a provider capacity. And the most sure way of building the provider capacity is to ensure that the national training package has a PPFP as a module. So the question is, has Kenya achieved this? Yes. The national training package now has PPFP as one of the modules. We also did all-site orientation, which is an activity where we target all staff within the facility and update them on post-pregnancy family planning. We also did clinical training because the staff we are expecting to provide immediate PPFP are in maternity and their core business has been conducting deliveries, not providing family planning. So we did clinical training. We equip these facilities to ensure that they have the right equipment. We also learned that it's very important for us to train a critical mass because if you train 1 or 2 providers, the next day they're transferred and then your services collapse. So it's very important to retain the skills of providers so that in case a provider leaves, you're replacing that person with a skilled person. And then it's very important to minimize unnecessary staff transfers. But when you look at PPIUCDs, we learned that it's not necessary to focus on everybody, but rather focus on a few interested providers to move the agenda forward. So once we build the capacity of service providers, it is important to create the demand for these services. And we learned that the local media, that is local FM stations, the local TV stations can give you a lot of time, airtime for free, and they gave us this airtime. to lead that culture change, because in Kenya we know that clients take up family planning after 6 weeks, but now we are changing that to inform them they can take up family planning immediately after delivery. Local media is a very key component. We also updated and engaged community health volunteers who play a very critical part in the community, so that as they do their routine work, they are disseminating accurate information on PPFP. We also did a human-centered design and developed some messages for PPFP and ensure that we paste these posters in facilities to ensure that clients get the key messages. We also came up with a very nice innovation whereby we use audio messages. Audio messages play at ANC and the postnatal ward, educating clients on the antenatal period, the intrapartum period, and the postnatal period, giving them key messages along all those along that continuum. And this makes sure that by the time the client goes to deliver, the client has key messages on PPFP. There's no, we can't be able to measure our success without data management. And the sure way of doing this is ensuring that our national HMIS tools capture immediate PPFP. And indeed, we've been able to achieve this great milestone as a country, where our national tool registers and summary tools now capture immediate PPFP indicators. But even as we waited for that, through formation of a technical advisory group on post-pregnancy family planning involving key stakeholders, we took these indicators and developed some stamps, and we were stamping the existing registers so that we can be able to capture these data even as we wait for the national tool to be updated. We also had a monthly summary tool, and then we used this data for decision making at the facility level and at the project level. Additionally, commodities are very key. Without commodities, no services. And we use the all-site orientation to update our service providers on inventory management, making the right quantification, timely ordering, which are very key. It's also very important for you to monitor the availability of these commodities at the end user, because we can have commodities at the central stores or regional stores, but no commodities at the end user. So that's a very critical component. Another key component that we learned was general family planning counseling is really not immediate PPFP counseling. For you to purport to do immediate PPFP counseling, a client needs to choose a method at ANC, be able to know the side effects and when to come back for review by the time she delivers. And to enhance this, we developed a flip chart for immediate post-pregnancy family planning that has been helping us, our providers, to give accurate information. The audio messages are also a great supplement to counseling, because a service provider can see almost 70 clients during ANC, and you don't expect them to give quality information. But these audio messages share this information with the client, so that by the time the client is going to the provider, they're just confirming the facts that they got from the audio messages. It's also key to counsel clients at ANC and immediate postpartum. As a new service organization is a very key element. And to champion this, we needed to identify champions, then create space, equip service delivery point, and manage commodities so that commodities are available where services are. We also ensure that registers are available in each and every service delivery point. Integration is a very key component, so that, for example, when a provider goes to give immunization after delivery, the BCGs, that provider can also provide immediate post-pregnancy family planning. As a new service, we needed to make sure that it takes root and become a routine service. And to do this, we figured out that the managers and the service providers require leading and managing skills, and we took them through a leadership development program for 6 months, and they're able to take this agenda and make sure that immediate PPFP becomes a routine service, so that even if the project leaves, the service continues. This was also augmented by formation of quality improvement team that routinely review the quality of service. Next. These are some of the tools that we've been able to develop. You can see the flip chart in the middle there, the PPFP counseling flip chart, some of the posters, the facilities, audio messages, and the media engagement. And then very importantly, the indicators, the PPFP indicators that have been included in the national register. So the question is, after doing all this, so what? Did we have any change? So next slide, please. This graph demonstrates the fact that immediate PPFP in the context of a broad method mix is feasible. You can see that in the intervention county, between November to June 2019, 21% of the clients went home with a method compared to 0.43% in the control county. And this is excluding LAM. So clearly, immediate PPFP is possible in the context of a broader method mix. Next slide, please. So this summarizes the numbers. We had, within this short period, one clients going home with IUCDs, over 4,000 going home with implants, among many others. Next. The private sector was not left behind. You can see that from the control county, only 0.3% of the clients went home with a method immediately after delivery, compared to 16.3%. So the question is, what do we do for the private sector? We need to implement the public sector intervention coupled with business management skills, and we improve collaboration with the public sector, especially around commodities and support supervision. Empanelment of these facilities to the National Insurance Scheme is also a key component because they're able to get a wider client base. Next. We wish to acknowledge the Ministry of Health, County Government of Meru, and County Government of Kilifi for helping us learn these lessons. Thank you.
Next, we have Riaz Mubarak Ali from Pathfinder, Mozambique. Over to you, Riaz.
Hello, good morning, good afternoon, everyone. Thank you, Laura. So I'm quickly going to share the experience that we have from throughout our implementation. And as this is just starting, this is one of our key champions from the work that we have at the maternity level, where they really are up and stand and say is that no woman goes out without being offered a family planning method, just considering that counseling and everything is available. So everyone should at least receive counseling prior to discharge. Next. Throughout this presentation, I am going to, can we have the next slide, please? Throughout this presentation, we are going to talk about briefly on the Mozambican context. We will be sharing how this evolved. And basically, in Mozambique, it went through the integration guidelines has started. So this is how we evolved to really embed and pack postpartum family planning, and sharing how we have been doing that in country and supporting the Ministry of Health efforts on that through either demand side work or through supply side, sharing some results and sharing some of our lessons learned and our experiences. Next slide, please. So basically bringing some of the context for Mozambique. Mozambique has almost 29 million inhabitants, mostly rural, and the heavier part of the population, I would say, are adolescent, youth, and young, 1/3 of the population. We have high fertility rates, higher mortality rates, and if we see the contraception, modern contraception rates, it's only around 25%. It was a huge jump from 2011. We have doubled, but it's still very low when we compare to the region. If we can see on the next slide, please. We see the region, and here Mozambique is still with the lowest MCPR in the region. So we have countries on the next slide, please. So here in this, we have from South Africa to Zimbabwe, almost every country with over 40%, but Mozambique is still around 25%. Next slide, please. So how the FP integration guidelines started? it was basically through the lessons learned and from different partnerships and colleagues. So we had experiences in country from JPIGO and GSI that were working postpartum. We using a systematic screening tool from 2013 and 14. And during the same period of time, we as Pathfinder were also implementing an intervention in Nampula and other provinces such as northern and in the south of the Mozambique, and embedding community-based outreach services, including offering of contraception, providing contraceptive within the immunization services. We have discussed that in one of our webinars, and also within the HIV services. Then all this fed into a process to really develop and harmonize the national strategy for integration of family planning. Next slide, please. So then when we went, we were able to really between this period to align, get the integration guidelines approved, and then we started with one facility per district approach. Additionally, we had those facilities that were already getting that support throughout different projects, but it was a really a national-wise effort to really support that rollout. And basically, this integration guidelines included all others, including postpartum and immediate postpartum, and it has all the rationale, tools, the recommendation aspects to consider in logistics as well. For example, co-location of commodities. Sometimes that minor thing is one of the biggest challenges. You do not offer contraceptive services or contraceptive based on the client's needs and willingness if that contraceptive is not really available at the room of delivery or within the ward. So that can be a blocking. And then data collection and reporting has all guidance, including all this processes in monitoring and evaluation were packed in this guideline. Next slide, please. So on this slide, it's just to show the current logbooks of maternity ward also includes the columns for family planning. So you can definitely ensure that postpartum family planning is being offered and you can capture. These tools might be getting reviewed this year, starting this year and early the first 6 months of the next year to be comprehensive and include additional data points. Next slide, please. So basically, from our approach, we have two slides where I'm going to briefly talk about our experience and how we have been tackling this. One, definitely, as you can see from the previous slides, it is working through the national health system engagement nationwide, and as the role that we play as a co-chair of family planning technical working group, that really is we keep that level of effort in ensuring that we don't miss opportunities. Supporting the assessment of the facilities to really identify what is needed, what are the bottlenecks, what is really required to operationalize the services. Training of providers, as we know, many of the countries, including Mozambique, sometimes we have some challenges, such as we have providers that gets out of the pre-service training institutes, but they didn't have had enough exposure or time for skills development on specific methods, and many times the postpartum is one of those weak areas. So and then mentoring. So assuming that only training is not enough, we should entail training, and right after that we have the strategy of supporting mentoring of those trained providers, starting right after the trainings, and we follow until we really we are using a digital app where we can track the progress and really identify if the provider is competent, requiring improvement, or has to be retrained. Sometimes we do not procure as Pathfinder contraceptives, but we do support in medical equipment supplies as needed. And sometimes some when we talk about renovation, is mostly on ensuring privacy and to be able to offer services. Next slide, please. So here basically is to share that we definitely work in both sides, in demand generation and service delivery. When we are talking about demand generation, is working with the communities, and here it's through the community health workers, the cadre of community health workers approved by MOH, the community leaders and important gatekeepers, and conducting those community dialogues to really work and dispel myths and misconceptions that still are around, and to really allow the clients and potential clients to really be aware and a request for services, and that entails collaboration with other partners. Within that, we have within the service delivery, as I previously mentioned, basically we work in training and mentoring, but we also work closely on a monthly basis doing the data review sessions and meetings. Next slide, please. On the next two slides, I'm just going to briefly show the data trends, how we started and how we have been in the last 6 months. For example, this is one of the projects that we are implementing in south part of Mozambique, in Maputo City and Maputo Province. The facilities where we're working, and we are here focusing on LARC, just considering that really LARC are those methods, implants and IUD, you can definitely link one client and a method, because for others, such as pills, it's sometimes we don't have really very accurate data. So that's just to give a sense and idea. We started in from scratch, 0 to almost 43%. On the next slide, we will see the intervention in the, that we are doing in the center of Mozambique and the northern part of Mozambique, in the one of the most populous provinces. And here we also can see that we started really from very below, around 2%, 10%, and it was evolving across the time. So definitely there is a lot more to do on these two provinces in the center and the north, as it is plateauing. But the quarterly, but the data frame is really from shorter periods. So now finally going to my last slide, I will say the key reflections that we can bring here. One is definitely engaging the decision maker level. It has been critical, not only the decision makers, but also the heads of the maternity. So that accountability and work close with the team, the nurses that are working at maternity, has been critical to ensure that comprehensive counseling and offering of method is happening within the maternity ward. It is happening throughout the antenatal care visit, and it is still happening during within other doors, so you don't miss opportunities. Ensure that you really have information not among clients, because we do generate demand, but sometimes the provider bias can affect the use of services. To ensure the competencies, it hasn't been a novelty to really see that many providers do not offer many methods because they don't feel confident enough to really administer or to insert an IUD or insert an implant, and that competency level, to ensure that it's important, the mentorship and the accurate training, the attitude and like promotion. And for example, I can just mention, just discussing on the shift in the shift times when you are changing nurses, if they talk about how much how it has gone throughout the night or throughout the day, make all the difference. So, and lastly, I'll really ensure that highlight that the referral mechanism to be sure that we are completing referral, we are being able to track referral, is also important to see that increase in uptake of services. And lastly, and not least, data has been challenging overall, but as much as we improve, we really get to start to see women and young women and getting services they need. Thank you very much.
Thank you so much. I would like to thank all of our panelists, and unfortunately, given the time, we do not have time for questions and answers, but for those of you who did type them in, we will get back to you. And note that the recording will be available as well as all the presentations. So stay tuned for future events, and thank you for joining today. Please visit our FP High Impact Practices website for this HIP as well as others, IBP Initiative website, and Family Planning 2020 website. Thank you very much.